GLP1 agonists, or glucagon-like peptide-1 agonists, are one of the newer classes of medications approved for the treatment of type 2 diabetes. All GLP1 agonists currently available in Australia are subcutaneous injections. They include glepaglutide, also known as Trulicity, semaglutide or Ozempic, exenatide or Byetta, liraglutide or Victoza, and liraglutide or Saxenda. Notably, the only two weekly injectables are glepaglutide and semaglutide. GLP-1 is a type of incretin hormone secreted by the intestines in response to food intake. The actions of GLP-1 are to increase insulin secretion from pancreatic beta cells in a glucose-dependent manner, to decrease the secretion of glucagon from alpha cells of the islets of Langerhans, to slow the rate of absorption of nutrients into the bloodstream by delaying gastric emptying, to decrease insulin secretion when blood glucose levels are near normal, and to directly act on the hypothalamus to improve satiety. These responses are blunted in patients with type 2 diabetes. The benefits of GLP-1 agonists are to reduce hyperglycemia with a reduction in HbA1c of approximately 1 to 1.5%, to promote weight loss ranging between 2 to 8 kilograms, with greater weight loss seen in patients with a higher baseline BMI, to provide cardioprotection. GLP-1 agonists have been shown to have cardiovascular benefits, including a 14% reduction in major adverse cardiovascular events, also known as MACE or MACE, a 12% reduction in all-cause mortality, and an 11% reduction in hospital admission for heart failure, with no increase in risk of severe hypoglycemia or pancreatic adverse effects. GLP-1 agonists also provide renal protection. Evidence exists for renal protection with long-acting GLP-1 agonists, although less robust than SGLT2 inhibitors. Meta-analysis demonstrates a 21% reduction in adverse renal outcomes, including worsening eGFR, renal replacement therapy, renal death, and development of macroalbuminuria. In Australia, GLP-1 agonists cannot be prescribed as monotherapy on the PBS. However, they can be prescribed for patients currently taking metformin, sulfonylureas, and/or insulin, and who have a HbA1c greater than 7%. GLP-1 agonists are not recommended for use in type 1 diabetes. Though it is not yet subsidized to be used in combination with SGLT2 inhibitors, they have different modes of action and are a good therapeutic combination. If prescribed together, one needs to be on private script. DPP-4 inhibitors and GLP-1 agonists should not be prescribed together as they work via a similar pathway. Apart from Trulicity, all the GLP-1 agonists need to be commenced at the lowest dose and up-titrated as per recommendations, as this reduces the incidence of adverse effects. Potential adverse effects are mainly gastrointestinal in nature. In particular, nausea is common, but generally mild to moderate in severity and transient. Patients tend to tolerate it better if given forewarning. Some may experience diarrhea, constipation, reflux, abdominal pain, and injection site reactions. Hypoglycemia is rare and usually only seen when used in combination with a sulfonylurea or insulin. Risk of pancreatitis, neoplasms, and gallbladder events are generally low. GLP-1 agonists are not recommended in pregnancy or lactation due to the increased risk of malformations. In summary, GLP-1 agonists are effective glucose-lowering medications. They have additional benefits of weight loss, cardio, and renal protection. They should be considered a second-line choice after metformin, especially in those who are overweight or obese, and those with cardiac or renal complications, in conjunction with SGLT2 inhibitors.